Hello, I'm Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us. Welcome to the webinar on a rare liver disease known as PBC or primary biliary cholangitis. We hope this webinar provides you with more understanding of this disease and its impact on our livers. Liver Health Foundation is proud to host these free webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with a mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, and some portions of Arizona and Northern California. There are over 100 different liver diseases. Some of them are known as rare liver disease. An estimated 300 million people worldwide are living with some sort of rare disease. Despite the name rare, between 3.5 to 5.9% of the population is affected by a form of liver disease. Tonight, our focus is on PBC, primary biliary cholangitis, a rare genetic liver disease that impacts the bile ducts and can cause scarring of the liver known as cirrhosis, which may require liver transplant. About 90% of PBC patients are women. Tonight, we will learn the reasons for the occurrence of this rare disease, its symptoms, stages, and treatments. Dr. Gina Choi will offer a review of PBC through a PowerPoint presentation at the beginning of the webinar. And then we will embark on a roundtable discussion with Dr. Choi, Dr. Ayub, and Dr. Gish. During the roundtable discussion, our wonderful experts will talk about their own experiences in working with PBC patients and their research on this disease. If you have any questions, please use Q&A or chat functions and post your question. Our experts will try to respond to all questions. And now my disclaimer. Please remember, information given by our experts is not substitute for advice given by your own physician or healthcare provider. This program has been made possible by an educational grant from Intercept Pharmaceuticals. We thank Intercept for their support. I'm happy to introduce Ms. Marlene Vincent, Director of Patient Advocacy at Intercept. Marlene is a professional with over 15 years of dedicated experience in the rare liver disease space. As the head of patient advocacy at Intercept Pharmaceuticals, Marlene leads efforts to ensure that voices and needs of patients are at the forefront of companies' initiative. Ms. Vincent, we are ready for your presentation.
Thank you so much, Farah. Good afternoon, everyone. It's a pleasure to be here today. I am Marlene Vincent, and I'm honored to be part of this important conversation about liver health and the impactful work that we're doing at Intercept Pharmaceuticals. As a company deeply committed to improving patient lives, particularly for those living with rare liver diseases like primary biliary cholangitis, I'm excited to share with you the strides we've made, our ongoing efforts, and the innovative approaches we're exploring to better serve this community. Next slide, please. Next slide. Yes, thank you. Our journey began in a small New York City apartment, and today we've grown into a commercial stage company known for our innovative approach to liver health. In late 2023, we became a wholly owned subsidiary of Alpha Sigma, one of Italy's leading pharmaceutical companies, strengthening our international presence, but without losing sight of our commitment to revolutionizing liver health through science, research, and innovation. Next slide, please. Next slide. Thank you. Since 2002, Intercept has made significant contributions to the PBC community. We played a key role in the name change from primary biliary cirrhosis to primary biliary cholangitis, and we brought the first new PBC treatment in 20 years to market. Till date, we continue to focus on advancing PBC innovation, research, and education. Next slide. Thanks. Right now, we're currently investigating a combination therapy using obeticholic acid, OCA, and bezafibrate for PBC. After completing phase 1 study, we moved into a phase 2 trial to explore the safety and efficacy of this combination. It is important to note that bezafibrate is not approved in the US for any indication. Next slide. We are committed to addressing health inequities, particularly those that affect timely diagnosis and treatment of PBC. We funded these 2 research projects to explore these disparities, and we're hosting community-based education programs to raise awareness about the importance of clinical trial diversity and reducing health disparities in PBC. Next slide. We are deeply engaged with the rare disease community, working very closely with stakeholders to advance education and research. Our efforts include elevating patient and healthcare provider voices, creating educational resources, and supporting advocacy group initiatives. Next slide. Thanks. So here are some examples. This is one of my favorite slides when I'm presenting. Here are some examples of our involvement with the community. You will see, go back to the photo slides. I'm sorry. Thank you. You'll see here some photos from the PBC Foundation International PBC Summit, patient conferences, and various advocacy events. These activities are vital in raising awareness and supporting the liver disease community and supporting all these patient groups we engage day to day on a daily basis at Intercept. Next slide, please. Thank you. And then the next slide. So I'd just like to update you on our regulatory progress in the US. Our supplemental new drug application was accepted back in February 2024, and we have an advisory committee meeting scheduled for September 13. The PDUFA date is set for October 15, and we're optimistic about the next steps in this process. So if this is a call to action, if you like to share your voice or your story in support of this upcoming AdCom in September 13, please reach out to us, to Intercept. You will receive my email and my number later at the end of the webinar. And if you're interested, you can reach out to me and I'll send you the instructions on how you can be part of this advisory committee meeting. Thank you, and I'll be back at the end of the webinar.
I had muted myself, so we appreciate Intercept support and thank you for your presentation, Ms. Benson. It is my pleasure to introduce Dr. Gina Choi, who has generously accepted to be the presenter for tonight's program. Dr. Gina Choi is Associate Professor of Medicine and Surgery, Associate Program Director of the Transplant Hepatology Fellowship Program at the University of California, Los Angeles. We all love it. It's called UCLA. She graduated from Stanford University and subsequently spent 1 year in Korea as a Fulbright scholar. She earned her medical degree at the University of California, San Francisco, and completed her internal medicine residency at New York University. She continued her training and education by a gastroenterology fellowship at UCLA and pursued an additional year of advanced training in transplant hepatology at the University of Pennsylvania. Dr. Choi has received numerous teaching awards and is the Associate Program Director of the Transplant Hepatology Fellowship Program. She focuses on treating patients with the complications of cirrhosis and manages their evaluation and care before and after transplant. Dr. Choi is well-versed in the newest approach to treat viral hepatitis and fatty liver disease. She's part of a multidisciplinary team employing the latest treatments for liver cancer. She's also interested in autoimmune liver disease, including autoimmune hepatitis and primary biliary cholangitis, and in caring for women with liver disease. Dr. Choi is board certified in internal medicine, gastroenterology, and transplant hepatology. She is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Choi, we are delighted to have you with us. Thank you for your support and participation. We are ready for your presentation.
Okay, thank you so much, Farah. Thank you so much for having me today. And I also want to thank Dr. Walid Ayub and Dr. Robert Gish for being the real experts on this panel. Okay, I'm going to begin sharing my screen now. Okay, share. All right, sorry, I'm going to go back a little bit. So for the next 15 minutes, maybe a little bit longer, maybe a little bit shorter, I'm going to talk about PBC, where we are now. So to kind of get a sense of where we are, these are my faculty disclosures. I'm going to talk a little bit about background, symptoms and diagnosis and treatment. And of course, during the roundtable discussion, we'll talk about the questions that the group had also generated. So just really quickly from a history perspective, I was a history major in college, actually, so I always liked this part. But basically, the PBC was actually first identified in London, and it was reported by doctors Addison and Gull at Guy's Hospital in 1851. But it wasn't until 100 years later where a paper was presented by the doctors in Cornell, where they talked about 17 patients who had PBC, and they really got into the presentation, the diagnosis, and how these patients presented. Fast forward 16 years later, and I always like to mention Dame Sheila Sherlock, who was the first female professor in the United Kingdom, and we kind of call her the maven of hepatology, but she established that PBC was an autoimmune disease. And of course, we've already mentioned here about how PBC underwent a name change in 2014. It used to be called primary biliary cirrhosis, but the nomenclature changed to primary biliary cholangitis. You can see Dr. Gish's name here on this paper, where they wanted to kind of correct their inaccuracy and remove the cirrhosis stigma associated with primary biliary cirrhosis to better serve patients with this disease. Really quickly about the pathophysiology, the pathophysiology of PBC is very complex. We do know that is an autoimmune disease of the liver. And what happens is that your immune system attacks the bile ducts in your liver, which causes cholestatic liver injury. And basically here you see the normal bile ducts that become inflamed, causing abnormal liver tests. When you have abnormal liver tests, this is kind of the natural history of PBC if it's not diagnosed and if it's not treated. So eventually you're going to develop symptoms where the most common symptoms are fatigue, pruritus, dry eyes, dry mouth. This is from the cholestasis that happens in the liver when your immune system attacks your liver. Ongoing inflammation or cholestasis will eventually cause fibrosis. Fibrosis has 4 stages, 1, 2, 3, 4, and stage 4 is cirrhosis. And at that point, you may develop symptoms of cirrhosis. And at that time, your doctor may refer you for a liver transplant evaluation. There is PBC recurrence. So let's pretend you get a liver transplant. There's a 25% chance that the PBC might recur. This can happen over a period of many, many years. But this slide kind of explains to you how important it is we want to prevent the complications of PBC, prevent fibrosis, prevent cirrhosis, and prevent the need for a liver transplantation. Just in terms of its epidemiology, we used to think that the median female to male ratio was 10-1, but more recent data finds that more men are actually affected, and it's actually 4 to 6 women for 1 man. The incidence and prevalence increases with age, with the peak between 60 and 79 years of age, but we typically identify it in people who are between 40 to 60 years of age, and we rarely see it in people who are less than 25 years of age. The prevalence and incidence between 2006 and 2014 is increasing. It increased from 22 to 39 per 100,000 persons. The prevalence increased from 34 to 58 per 100,000 women during this time period. For men, it went from 7 to 15 per 100,000 men. But we see here that the incidence is the same, which tells us that we are successfully identifying and treating patients with PBC. I think it's important to note that there is a changing epidemiology of PBC in the United States. Traditionally, non-Hispanic white patients were disproportionately diagnosed. But in this ethnically diverse cohort of about 3,500 patients, we found that The incidence and prevalence of PBC in racial minorities are rising, particularly among Black and Asian American patients. In this study, 21% were Hispanic, 8% were African American, and 7% were Asian. Again, it's really difficult to accurately make these epidemiologic estimates due to the healthcare disparities that we do see and are aware of in our country. So now moving on to symptoms and diagnosis. So many patients have no symptoms at diagnosis. So for example, a patient will go for their annual physical and the doctor will notice that their liver test, particularly their alkaline phosphatase, is elevated. When patients do have symptoms with PBC, the two most common ones are pruritus or itchiness. This itchiness most often happens at night. And also fatigue. And so fatigue is a hard one because lots of diseases and non-diseases can make someone tired. But fatigue is important because it really impairs the quality of life of someone. It disturbs your sleep. It can certainly cause depression. So even though it is very common, it's actually something that we all struggle with, both as providers and as patients. There are some common extrahepatic symptoms, which mean that symptoms that aren't directly related to your liver. Most of them are things like dry eyes or dry mouth, which we call Sika syndrome, and thyroid disorders. Thyroid disorders like hypothyroidism is so common among my patients that I actually check TSH every 2 years. So I've been talking a lot about cholestatic liver disease. What does that really mean? So whenever I talk to my patients, I always say, imagine your liver is like a tree, and the branches are the bile ducts and the leaves are the liver cells. So if something irritates the branches, then the alkaline phosphatase or the total bilirubin will rise in your blood. And we check that by checking a hepatic panel. If something irritates the leaves or the liver cells, the AST and ALT will go up. So for PBC, we said it was a cholestatic liver disease. So very simply put, the first thing we notice that goes up is the alkaline phosphatase. So how do you make the diagnosis of PBC? Now that you know my tree branch leaf example, you actually, the diagnosis is actually pretty straightforward. You only need two of the following three things. One, an elevation of the alkaline phosphatase. We talked about how that's a blood marker that's released when the bile ducts or the branches are irritated in your liver. You can have a positive antimitochondrial antibody, which is an autoimmune blood test. And this is positive in 95% of patients who have PBC, but that means that 5% test negative for this blood test. And if you have a high ALK phos and you have a woman with hypothyroidism and she's itchy at night and she's really tired, but the AMA is negative, that's when you would consider doing a liver biopsy. But most often, we rarely do liver biopsies to make the diagnosis of PBC today. So in terms of treatment, there's a lot going on in treatment these days. So the first line treatment is this medication called UDCA or ursodeoxycholic acid. It's actually the first line treatment. It was approved in 1997. And the dose is weight-based, like a lot of pediatric medications. So it's 13 to 15 milligrams per kilogram per day. It's usually given twice a day. The tablets come in either 250 or 500 milligram iterations. And depending upon insurance, some insurance will cover for the 250, some insurance will cover for the 500, some insurance will cover both. And the reason why this medication is so important is because studies a long time ago showed that it decreases death and liver transplant risk for our patients. Those are really important outcomes. So when you start Ursodiol, how do you assess if your treatment with your Ursodiol is working? So this is a table that kind of shows all these different published criteria that doctors use. And I really want to focus on the purple circles here. We see that alkaline phosphatase, which is one of the blood tests I talked about earlier, is followed. AST, another blood test that I talked about earlier that comes from the leaves of the liver. The bilirubin, the albumin is a protein that the liver makes, which also gives a reflection of how good your liver is working and doing its job. But the reality is that a lot of patients, and they say up to 40%, don't respond to Ursodiol. So if there's an inadequate response, we often ask our patients, are they taking the medication? Some people weigh average weight gain of 3.6 kilos. That's 3.3 times 2.2 pounds per kilo. So that's not insignificant. Some people get hair loss, loose stools. But if they're doing all these things and they still are not responding to the ursodiol, you have to think about second-line treatment. So treatment no longer stops at ursodiol. So a long time ago, since 1997, physicians used to start ursodiol and kind of cross their fingers and hope for the best because we didn't have any other options, right? But now I'm going to talk about some of the new options that we have. But before I get to that, I'm going to talk about what is our goal. So if we start treatment, I've talked a lot about alkaline phosphatase, et cetera, but what is our goal? In the beginning, we used to start urso, hope for the best. But nowadays, we're figuring out that normal bilirubin and normal alkaline phosphatase is actually associated with improved survival, meaning that people live longer if they have a normal alkaline phosphatase and bilirubin on treatment. This more recent study just came out this past year, where we found that normal alk phos again is associated with a better complication-free survival, meaning that the lower we can make your alkaline phos as close to normal, the longer we believe that you will have a complication-free life and live longer. So with that, I talked about ursodiol in 1997. Let's talk about second-line treatment. So the FDA approved obeticholic acid as second-line treatment in May of 2016, so many, many years after UDCA hit the scene in 1997. This medication works with ursodeoxycholic acid, and it's a, quote, farnesenoid X receptor agonist. So they believe that this regulates genes involved in how your bile acid works in your body. And so they did this study where they found that people who got ursodiol and obeticholic acid had a much more significant improvement in their alkaline phosphatase at after 1 year of treatment. So when we think about PBC second-line treatment, you know, who do we think about? We think about people who are not having a good reduction in their alkaline phosphatase on ursodiol. With this medication, they started at 5 milligrams daily. And if they're tolerating the medication well, you increase it to 10 milligrams daily after 3 months. That's the highest dose that they recommend. And we do not use this medication in people who have cirrhosis or decompensated cirrhosis, meaning people who have cirrhosis and symptoms of cirrhosis, including ascites, low platelets, a history of bleeding, etc. You want to check labs every 3 months and also check to see if there's any itching, because some patients do develop itching on this medication. You might have also, if you've been on the scene with PBC, there's another second-line treatment called fenofibrate. It's off-label, meaning that this is not FDA approved for the study of for the treatment of PBC, but a lot of patients have interacted with this medication. This is kind of like a takeoff of bezafibrate, which was approved for PBC in Europe, but this version is not available in the United States. So we kind of extrapolated the data and use fenofibrate instead. And the reason why we do this, fenofibrate is bezafibrate's cousin, is because they did the study in Europe where they found that patients who got bezafibrate at 24 months compared to people who didn't get it, 31% of those patients got a normal alkaline phosphatase, normal bilirubin, and normal AST and ALT. So in terms of other second-line treatment, so we talked about urso as first line. If urso doesn't work, you want to consider second line. Obeticholic acid was first, 2016, the first medication for PBC since 1997. We have a couple of new kids on the block. The first one is elafibranor, which is also approved for the second-line treatment for primary biliary cholangitis. And it actually just received approval from the FDA for this indication on June 10th, 2024. So just to really kind of quickly, the FDA approved this medication because they found that elafibranor versus placebo, 47% of patients on this medication hit an alkaline phosphatase of less than 189. And that was at 52 weeks, and that 15% actually hit normal. I talked about how pruritus is one of the most common symptoms of PBC. Elafibranor did not show any statistical significance in improving people's itch. Then just literally a week ago or 8 days ago, the FDA approved a third medicine for second-line treatment for PBC called seladelpar in addition to ursodeoxycholic acid. And this was, it's 10 milligrams a day. And this was based on a study that again showed that seladelpar compared to patients who didn't get it, 42% hit an alk phos of less than 189 at 12 months, and that 25% had a normal alkaline phosphatase after 12 months of treatment. And unlike the first two second-line treatments that I mentioned, in terms of seladelpar, there was an improvement in how patients felt in terms of itching on this medication. So I just kind of created here a quick little PBC timeline to kind of share with you. We talked about how it was first reported in London in 1851. It got named PBC in 1950. In 66, we figured out it was an autoimmune disease. In 1997, we got first-line treatment with ursodeoxycholic acid. And then in the past, 10 years, it's been a virtual, exciting, awesome time where PBC got a new name. A new second-line treatment emerged in May of 2016, and we have about 8 years of data now supporting the use of obeticholic acid. And just in the last 2 months, we have 2 new medications for second-line treatment for PBC, including seladelpar and elafibranor. So in terms of a quick summary, we discussed that PBC is a chronic autoimmune condition. The prevalence of PBC is increasing and impacting more men and minorities. The diagnosis can be made with a simple blood test. You rarely need a liver biopsy. Treatment includes first-line ursodeoxycholic acid, followed by potential second-line treatments if your alkaline phosphatase does not improve enough, including obeticholic acid, elafibranor, and seladelpar. Alkaline phosphatase is the important marker that we follow in terms of, is the disease getting worse? Is the disease getting better? Is the medication working? Is the medication not working? And of course, all of this is to prevent cirrhosis and the complications of cirrhosis. Okay, that's all I got for you guys.
Well, thank you so much, Dr. Choi. This was
Sure.
a lot of information, And I understood it now a lot better of what I was reading. So thank you. Great
Sure, no
presentation.
problem.
Yeah, it was great. So it is now, we're going to now start our roundtable discussion. And it will be a conversation between Dr. Ayub, Dr. Gish, and Dr. Choi. We had received some questions from people which I have forwarded to all of our doctors, and they can look at them and respond, or they may have other questions themselves that they think patients should know. So that is, again, just fine too. We just want people to have a better understanding of PBC. And also, one of the things they had asked, and I don't think I put it on our list, is having what other things like diet, exercise, what are those other things? So we can talk about all those. But right now, it's my pleasure to introduce a good friend of Liver Health Foundation, Dr. Walid Ayub, MD, FASLD, AGAF. Dr. Ayub is Professor of Medicine, founder and director, Autoimmune and Liver Disease Program, Associate Medical Director, Liver Transplant Program, Cedars-Sinai Medical Center, Department of Medicine, Karsh Division of Gastroenterology and Hepatology, Comprehensive Transplant Center in Cedars-Sinai, which has no need to introduce the hospital. Everybody knows Cedars-Sinai. Dr. Ayub achieved his medical degree at Creighton University School of Medicine in Omaha in 1999 before taking up residency at UCLA West Los Angeles Veteran Administration Hospital. Between 2002 and 2006, Professor Ayub conducted fellowships in hepatology and gastroenterology at Cedars-Sinai Medical Center and UCLA, respectively. He then became clinical assistant professor of medicine at Stanford University until 2012, when he moved back to Cedars-Sinai Medical Center, where he is currently professor of medicine, director of autoimmune and cholestatic disease programs, and associate medical director of the liver transplant program. Dr. Ayub is board certified in gastroenterology and transplant hepatology and has been involved in several clinical trials investigating pharmacological therapies for liver impairments, cholestatic liver disease, and viral hepatitis. He is currently a primary investigator for clinical trials assessing the efficacy of novel agents in the treatment of MASH, primary biliary cholangitis, the subject of tonight's webinar, and primary sclerosing cholangitis. Dr. Ayub has been invited to speak at the digestive disease meetings and has moderated sessions at the American Association for the Study of Liver Disease and the American Transplant Congress, discussing liver cancer therapies and management, as well as treatment of viral hepatitis and quality of organs in the solid organ transplant recipient. Dr. Ayub served as a member of the Hepatology Associate Committee of the American Association for the Study of Liver Disease, that's AASLD. He is also a fellow at AASLD and a member of the American Gastroenterological Association, American College of Gastroenterology, and American Society of Transplantation. Dr. Ayub has also held responsibilities as editor of Journal of Pancreatic Disorders and Therapy and a reviewer of a variety of journals, such as the American Journal of Transplantation, Liver Transplantation, Journal of Clinical Gastroenterology, Journal of Hepatology and Digestive Diseases and Sciences. Dr. Ayub is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Ayub's specialties: hepatology, hepatitis B, hepatitis C, hepatitis D, primary biliary cholangitis, primary sclerosing cholangitis, autoimmune hepatitis, cirrhosis, portal hypertension, end-stage liver disease, acute liver failure, liver cancer, liver transplantation, and fatty liver disease. Dr. Ayub, welcome, and thank you for your participation. I know you're very busy, and I appreciate your support.
You're welcome.
Now I will introduce our other panelist, Dr. Robert Gish, who is also a very good friend of Liver Health Foundation and has been guiding us along the way. Dr. Gish is an adjunct professor of medicine, University of Nevada, University of Nevada School of Medicine, Las Vegas, and Reno. Adjunct professor of pharmacy, University of California in San Diego. Clinical professor of medicine at Loma Linda University. Staff physician at Loma Linda University's Liver Transplant Clinic in Las Vegas. Medical director of the Asia Pacific Health Foundation in San Diego, and the medical director of the Hepatitis B Foundation in Doylestown, Pennsylvania. Dr. Gish attended pharmacy school at the University of Kansas and subsequently obtained his medical degree from the University of Kansas Medical School in Kansas City. He completed a 3-year internal medicine residency at the University of California, San Diego, and a 4-year gastroenterology and hepatology fellowship at the University of California, Los Angeles, which included transplant medicine. Dr. Gish is a fellow of the American Association for the Study of Liver Disease, the American Society of Transplantation, and the American College of Physicians. He has served on the editorial boards of American Journal of Gastroenterology, Hepatology, Journal of Hepatology, Digestive Diseases and Sciences, and Gastroenterology, among many others. He has co-authored a public health policy for liver health in Vietnam, focusing on HBV, and is also assisting with the development of viral hepatitis healthcare policies in Georgia, that's the country of Georgia, Armenia, and the Philippines. Dr. Gish was a major early contributor to decipherment methods for the detection of a hepatitis B and C virus and characterizing its epidemiology and clinical presentation in humans. He was also in studies that led to the genotype classification strategies and methods now in use worldwide. He has published more than 700 original articles, review articles, abstracts, and book chapters. Dr. Gish is currently seeing patients both in person and via telemedicine at various clinics in San Diego, Folsom, San Jose, Santa Rosa, Las Vegas, Reno, and via Telemed2U. Dr. Gish is also a member of our Medical Advisory Council. Dr. Gish, thank you and welcome to PBC webinar. We are happy to have you with us. So over the past few days, I have received questions from the audience as well as those who couldn't be with us tonight. I have submitted the question to our presenters to review and to respond. However, the audience members are welcome to post their questions on Q&A and chat tabs, and our experts will try to respond to them. Dr. Ayub, would you like to take the helm and start with the questions?
Sure. Thank you, Farah, for setting this nice webinar. There was a few questions that Dr. Choi already hinted to. So a couple of them addressed what's the association between autoimmune hepatitis and PBC. So Gina, you want to?
Yeah, sure. So autoimmune hepatitis and PBC, they're both autoimmune diseases of the liver. So we talked earlier about how one is predominantly attacking the leaves or the hepatocytes, and one is attacking more the bile ducts or the branches of our tree analogy. Now, there is a subset of patients who have both autoimmune hepatitis and PBC, right? And so those are the patients who have elevated alkaline phosphatase, but they also have elevated AST and ALT. And you actually have to treat both diseases.
Very good. And as Dr. Gish alluded to in our chat room, sometimes you need a liver biopsy to assess for that. And there's a very important question. Actually, I found a statement. Actually, it's open for anyone. What's the association between PBC and osteoporosis? And I think that's a very important aspect of management of patients with PBC. Bob, Dr. Gish, you want to take that one?
Absolutely. So every patient with PBC needs a DEXA scan baseline, and then a DEXA scan every 2 to 3 years. Vitamin D levels super important also. Often they can be vitamin A deficient if there's significant cholestasis. And bone disease is important because 2 of the new medications that came out for PBC have some information in their package insert about bone fracture risk. So definitely need to be aware. That's a great question.
Very good. And let me follow up with you, Dr. Gish. Gina mentioned in her presentation, fatigue is one of the common symptoms of PBC. So there's a question is, what do you do for fatigue in patients with PBC?
I think the first thing is making sure that you have their itching under control, because that can result in a substantial problem with sleep disorder. So fixing sleep is super important also. And also, I'm a strong believer in caffeine as a great benefit for patients with any type of liver disease. It provides good energy for people also. And then, of course, managing depression, managing other issues with their medical care will, I think, improve their overall energy and help both with sleep and their fatigue. And I really disagree with what I see in lots of slide presentation and articles that most patients with PBC are asymptomatic. I think this is a symptom where we as providers aren't listening to our patients very well. I believe 70% of my PBC patients I've seen at initial consult have very significant impacts of PBC on their life, including stigma. That's one of the reasons we changed the name from cirrhosis to cholangitis, as Gina was kind enough to cover. So we really need to listen to our patients and really work on symptoms of itching, sleep disorder, fatigue, depression. Great questions. Thank you.
Very good. I might add to it, there are some studies showing actually exercise is also good medicine to help with fatigue. but it's a vicious cycle. Patients are already tired and we push them to exercise, but there's European studies that showed, exercise for, as minimum as 15-20 minutes a day could make a different long term in the management of fatigue. Gina, one of the audience mentioned about worried about risk of transmission of PBC to her child. They're planning to have a family. She has PBC. So is that something she should be concerned of?
Yeah, that's a great question. So, we talked about how it's an autoimmune disease, right? And so people think that PBC is triggered in a patient who's genetically susceptible and triggered by some type of environmental factor, right? But right now, there are no recommendations. The correlation is not there. It's not strong enough where we recommend that, hey, if mom or grandma has PBC, we have to screen the daughter. I think that it's really important, like whenever you meet a doctor and they do a thorough, history and physical, they ask, do you have a family history of breast cancer? Do you have a family history of diabetes? So they ask you, do you have a family history of autoimmune disease? At that point, you could say, oh yeah, my mom has PBC, and so that way it kind of gets the patient, the doctor thinking that if your alkaline phosphatase ever goes up, that's something they can consider, but the association is not strong enough where we recommend that family members get screened.
Indeed. Now, there was another question, just to repeat what Dr. Choi mentioned in her presentation. To make a diagnosis of PBC, patient needs to have 2 of 3 criteria: positive AMA, elevated ALK phos, or a liver biopsy proven PBC. 2 of the 3 will clinch the diagnosis. So if a patient has a positive AMA, it's very important to follow with their physician to assess the rest of the liver test, make sure the ALK phos is not elevated, because that will trigger a diagnosis of PBC and a different management pathway for this patient. Now, one question that actually caught my attention, and I think the misinformation, one of the audience mentioned if a person has PBC, she heard that their life expectancy is 10 years. And that's completely wrong. Patient with PBC could live for many years. As Dr. Choi mentioned, usually diagnosed between 40 and 60 years old, but it's not a death sentence. And the key is to catch it early so we could start treatment early to improve quality of life, symptom, and slow down that progression to cirrhosis if we can. And recurrence after transplant, there was a question. Dr. Choi, you want to emphasize what you said in your slide briefly?
Yeah, sure. So, so there is a risk of we say about 25%, back in the early 90s when we were doing liver transplant, PBC was actually the #1 indication for liver transplant. I think now that we're identifying patients sooner and treating patients with better medications, the need for the PBC as an indication for liver transplant has drastically fallen in the United States. But if you were given a liver for PBC, we say about 20 to 25% of patients do have recurrent PBC. And we can actually prevent that by happening by starting you on ursodiol immediately after liver transplant, even if your liver tests are normal. And that has been shown to reduce the recurrence of PBC after liver transplant.
Very good. I'm going to circle back to Dr. Gish, to make so he can emphasize an important point. Some patients ask, well, if there's no cure for PBC with the current medicine, why should I take it? And usually my answer to them is there have been many studies showing there's a decreased rate of need for liver transplant or developing complication from advanced liver disease and portal hypertension. So Dr. Gish, how would you address your patient when they ask you that question? The optimistic patient, I would say, not the optimistic.
Dr. Ayub and Dr. Choi, you're very aware, and I think our patients, that most of the diseases we deal with are not curable. So what do we have? The miracle of hepatitis C, of course. And of course, hepatitis B, we're not curing, but we're suppressing. But we are changing outcomes. I've managed over 300 patients with PBC. I think of 5 that went on to transplant because I have been very active in URSO and getting to full dose, making sure everybody's on URSO if they can tolerate it, making sure they're on the correct dose, because 20% of PBC patients are not on URSO. and 40% are not on the correct dose. So we really have to be focusing on that. And then I'm definitely a big believer that if the alkaline phosphatase is not normal and they have F2 fibrosis or more, they need to be on second-line therapy. I've used OCA in over 70 patients, very good tolerance to this medications. And we're definitely getting alkaline phosphatase much closer in combination with urso, definitely below that 1.67 or 1.5 times upper limits of normal. And I'm going to push even harder, whereas obviously we've got new second-line therapy that are available. There's even this concept of using triple therapy that if people are progressing. So I tell my PBC patients a chance of them needing a transplant or getting liver failure if they're under correct care, and I'll call it a more aggressive care, the chance of needing a transplant's under 5%. So this is not a death sentence. It's not even a sentence where they're going to go to transplant if we're aggressively managing them. And Gina, thank you for that message about normal alk phos, normal bilirubin. And it should be normal bilirubin under 0.6, and it should be normal direct bilirubin under 0.3. The direct bilirubin and GGT message is just not strong in the PBC community. I hope we can work together to fix that.
Yeah, I definitely feel that GGT has had a renaissance. I find myself checking that more and more. And I find it very, very helpful. But just like Dr. Gish said, we don't have a cure for diabetes. We don't have a cure for high blood pressure, but if you take medications to make sure your blood pressure is at the right goal and your glucose is well monitored, you actually, prevent things like heart attacks and renal failure. So I think that it's important. Just because you can't cure it doesn't mean that we can't treat it and help you live a long, happy life.
And as I said, we have data now showing, from ursodiol and obicolic acid or Ocaliva, showing significant decrease need for liver transplant and preventing patients from dying from PBC. So even though we don't have a cure, we could impact the trajectory of the disease.
There was a question from a patient, and I just asking whether that's an old data and it doesn't apply anymore, that his understanding was that life expectancy after being diagnosed is about 10 years. Is that correct anymore, or is that an old thing before medication was available?
Yeah, as Dr. Cho mentioned, life expectancy is quite long for patients with PBC, and Dr. Gish nicely mentioned from his practice, only 5% of his patients end up getting a transplant out of 300 patients. So a patient could live to their 70s, 80s. My oldest patient is 87 with PBC, and she still go to dancing every week. So that should give hope to all the pessimistic about PBC and what impact. But the key is to get it identified, diagnosed, and treated appropriately by the right physician using the appropriate medication at the right dose.
Our prevalence is, I know you said, Dr. Choi, about that, but in the US, and I saw that you said now it looks like men are kind of competing with women to be just at the same level as far as having PBC. What causes, it's all genetic from what I understand, so it's somewhat environment, like the guy who was asking, he's worked in print shop and he had to clean the presses with chemicals. At that time, when he was working, there wasn't any environmental friendly cleaners or anything like that. And that was a long time ago when he was in college. And he said he did that in 1995, and now he's been diagnosed with PBC. So environment also, and what chemicals are around us, plays a big role in having PBC, not only having the gene of it being in us.
So I don't think that there are any known environmental chemicals or elements. There's a lot of hand waving when we talk about, why these diseases occur in the genetically predisposed individual, right? I think when we think about genetic environmental triggers, we think more like diet, bacterial infections, etc. But there's no known association that I'm aware of a certain chemical. I think in terms of men, traditionally we used to think that for every 10 women, 1 man had PBC. Now we know it's more 4 to 6 women for 1. I think that practitioners just weren't aware of looking for PBC in men. And so we believe that they were often diagnosed later at later stages of disease, right? So, but I think that now that more people are aware, we should think that, in my experience, men with PBC do tend to have more serious disease. I don't know if Dr. Ayub or Dr. Gish want to add to if they know of any environmental triggers or anything specifically.
There's articles from Northeast England where there's one of the densest clusters of PBC that associate it with groundwater contamination, heavy metals, and also there's been some suggestions about hair dye that's arisen. The strongest association is with E. coli urinary tract infections. And this E. coli has some similarities to these proteins like that mimic pyruvate dehydrogenases, which is one of the targets of the antimitochondrial antibody. So these are, I'd say, supportive or suggestive. It's not absolute, but I think this is part of a family of triggers that take place that result in these autoimmune disorders.
I mean, I agree. As Dr. Kish, E. coli has been linked in the past. CMV has also been associated with certain population. But I think it's a more combination of more than one thing, one factor that leads to the trigger of PBC. There's a lot of study looking at the genetic makeup of a person. There is certain, we call them HLA haplotype found more in men than women, that men with PBC have them compared to women. But, it's more of a, I would say, low-hanging fruit, slow signal, but it's not a complete signal that will trigger the disease. We still don't know the exact signals that will lead to PBC.
Very interesting disease that most people don't know about, don't hear about, and of course that's why it's called rare disease. But it has been an eye-opening webinar for me personally, and also I think for everybody, because as I said, I had heard very little before about PBC and had never met anybody who had that disease, but now I understand more. Dr. Gish, you said something interesting for women. You said something about hair dye. Most women use hair dye. Some, of course, guys now use hair dye as well, not only just us women. So, and there are so many of them in market. Everybody is advertising they're good, they're this, that, natural, and avocado in them, and that kind of stuff. So is hair dye really, and are people really studying to see if hair dye can cause PBC or even cancer, brain cancer, because it's on our heads?
I don't know about brain cancer, but there was some articles 15 plus years ago that hair dye was potentially one of the triggers. So remember, it's genetic predisposition with one or more triggers is what Dr. Ayub was talking about. And these associations are pretty weak. These go through large population studies. And do you make an absolute connection? I mean, how many hair dyes, what hair dye you have, or you're drinking groundwater, does it have selenium or arsenic or strontium? These are all difficult associations. So that's why I'm using the word suggestive or supportive as possible triggers.
Anything else from any of you, or are we good? Dr. Ayub, any other questions?
No, I think we're good. I mean, we covered a great area. It's a golden era for patients with PBC. We have 2 new medicine who just got approved and 2 prior ones. So I think it's a great time for patients with PBC. So many choices.
Well, thank you so much. This was a great roundtable. As I said, yes? Did you want to say something, somebody? a great educational webinar, and I know I learned a lot, and I'm sure people do too. And I want people to know that our presenters are here as volunteer physicians. They care deeply about liver patients. They care deeply about you, and they use their own personal and family time and share their expertise with all of you in support of our efforts in helping liver patients and raising awareness of liver disease. So my personal thank you and heartfelt appreciation to our doctors for their kindness and compassion. Thank you, Dr. Choi, for your great presentation. We're grateful for your support. Thank you, Dr. Ayub. Your kindness in supporting our efforts is greatly appreciated by all of us and our patients. Thank you, Dr. Gish, for your continued friendship and participation and guidance. This is a good point now to hear a bit more about Intercept's work. Please allow me to invite Ms. Marlene Benson to join us for just a few minutes. Marlene, are you here? Please talk to us.
I am here trying to get off of mute. Thank you so much, Farah. Thank you, Dr. Ayub, Dr. Choi, and Dr. Gish for this incredible presentation and roundtable. Now, just to finish the last 2 minutes, I want to share with all of you a great resource that we have at Intercept, Interconnect. If you can move to the next slide, please. Okay, so through Interconnect program, we offer comprehensive personalized support to patients. These include assistance with insurance coverage, personalized care coordination, and access to educational resources. So please feel free to reach out to our Interconnect team at Intercept if you're interested to learn more. Next slide, please. As I mentioned here, you can find my name and my email address, so you can reach out to me if you have any questions. So thank you so much for your time and attention today at Intercept. Again, we remain dedicated to supporting the liver disease community through innovation, advocacy, and patient care. Please do not hesitate to reach out again to me if you have any further question or you're interested in participating at the open public hearing or sending your story in support of the advisory committee. Or if you have any questions about the Interconnect program at Intercept, please email me. Thank you so much, Farah, and thank you to everyone that presented today.
Thank you, Marlene. A couple of more information. Please join us on September 21st for Walk for Your Liver Los Angeles in Santa Monica. This is our annual walk in support of liver patients. During the walk, we will feature many liver patients as they share their liver journeys, stories with us and our walkers. There will be refreshment for all. Children are absolutely welcome to enjoy face painting, balloons, music, and more. Please visit our website to register to walk. Liver Health Foundation will host a webinar on late-stage liver cancer on September 12th from 5:30 to 6:30 p.m. Pacific time. Please join us by visiting our website and registering to attend the cancer webinar. This webinar is sponsored by a grant from AstraZeneca Pharmaceutical. The speakers at the cancer webinar are Dr. David Emagawa from UCI, Dr. Edward Mena from CLRI, Dr. Gangdeep Brar from City of Hope. Our presenters will discuss liver cancer, therapeutic treatments, and of course, liver transplant. Liver Health Foundation is on all social media sites. We announce our events, programs, and news on our website and social media outlets. Please visit us. And finally, happy Labor Days to all. Be well, take care of yourself, and we will see you on September 12th at the Liver Cancer webinar. Thank you. Thank you, our doctors. Thank you, Intercept. Have a wonderful time between now and September 12th. Good night.